Well, hi, and welcome back to another Lunch and Learn. It is Tuesday, September 9th, 2025, for anyone who's listening on replay. This whole series, for those of you who are following the channel, as you know, is to target information that's relevant to patients that I take care of, for people who are looking for credible, accurate information in this day and age. And so I have brought on a friend and a colleague, Dr. Kaul, who is a rheumatologist here in Atlanta. She and I share a ton of patients, and I wanted her to come give us some information about if you are someone struggling with pain, and you, especially if you're in the hypermobile POTS, MCAS family of folks. What do you need to know about autoimmune disease? What tests need to be ordered? What your primary care doc be doing? And then what is she thinking of as she's trying to discern, is this autoimmune or is this not? So welcome to the, not podcast, welcome to the Lunch and Learn.
Well, thank you so much, Kara. And I'm really excited to be here and talk about this. I think, rheumatologists definitely get roped into the group of specialists that patients in this area need to know about. They need to know what rheumatologists do. They need to understand how we can help and how we can't help in these situations. And the really tough part about what I think a lot of patients with the MCAS, EDS, uh, and
Pod.
POTS,
Yeah.
POTS like triad are encountering is the fact that, like, when you and I trained, which
Mhm.
we're not that old, but when we trained, these disease entities did not exist. And it's not that they didn't exist. They've always existed. It's just that they weren't identified. We
Right.
didn't recognize the patterns.
Right.
And I will say that the MCAS patients are particularly challenging to differentiate
Mhm.
because the symptoms that patients with MCAS can have overlap with so many other diseases and
That's
autoimmune diseases for sure. And
mhm.
so, I think it's a really great question of, well, how does the rheumatologist play into it? So now, the reason I gave that little prelude is the fact that remember when the patients who are listening go to their rheumatologist, if they're anybody who look a little older than our age group, they definitely did not learn this along
Yeah.
the way.
Yeah.
And if
That's right.
they're younger than us, they may be, more familiar, but still there's a lot of discrepancies with the guidelines, the classification criteria, and patients out there might feel very frustrated because what they feel is so real, and it
Yeah.
absolutely is real. There's symptoms that you're feeling. The problem is, and this is a general across the board with medicine in general, is when things are easily measurable by a blood test, an imaging study,
Mhm.
or just what we see with our eyes externally, like a
Mhm.
rash on the skin, it's a lot easier for us because we can just biopsy that and categorize.
Mhm.
But similar to a lot of our autoimmune diseases, although MCAS does not fall directly into an autoimmune category, at least not at
Right.
this time, although we know there's a lot of overlapping pathways, it's all about this symptom, and it's a clinical diagnosis, and
Mhm.
that's where the challenge comes, and that's where the patients, I think, unfortunately, are getting a lot of the feeling of, like, maybe that they don't know where they fit into this or
Mhm.
what's happening. But the beauty of it is, though, of all, and right now is when we're actually understanding more, and people have really started to focus on understanding how these conditions are both in the lab and then also clinically. Like, how do we help the symptoms? But when you come to a rheumatologist, that preface is to help you understand that um, MCAS kind of falls in this you kind of call it like an orphan disease, where it just doesn't have this, like, home where someone can clearly say. So you do want to be really careful when you are interviewing or researching the doctor that you're going to see.
Mhm.
You know, going from doctor to doctor is very, very traumatizing. And so
Yeah.
you might as well save yourself a little bit by, even before you make that appointment, try to do a little research. See if you can
Mhm.
find something online. I know there's a lot of support groups. See if you can call the office and just ask, hey, does Dr. So and so, the rheumatologist, have an interest in this? Do they
Mhm.
see this? Because then you'll save yourself this, like, going there and feeling dismissed and rejected and all of those things. And so I think those could be some things that that patients can do practically to
Yeah.
help them figure out if they've found the right person. But, your question was about seeing a rheumatologist. And I think absolutely a rheumatologist falls into the category of the different types of specialists that a patient with MCAS may need to see.
Right.
So there are autoimmune diseases that overlap. The more common ones would be like autoimmune thyroid disease, celiac,
Mhm.
lupus. And because the symptoms can also be similar, getting tested for that would be an important thing.
Yep.
You wanted to know a little bit about what I would recommend for testing if patient.
Yeah. Yeah,
Yeah.
absolutely. And Sjogren's is the other one that comes up
Oh, yeah, of
for a
course.
lot of those.
That's a
So
one.
I
Yep.
think any good primary care doc should be able to like order a basic autoimmune panel for patients. And I just want to make sure this is me picking your brain. Like,
Yeah.
let me make sure my list is right. What do you
Sure.
recommend
Well,
people?
I would say
Or,
that you definitely want to get thyroid studies
Mhm.
checked.
Yep.
You definitely want to get iron levels checked. That can
Mhm.
sometimes be a clue that somebody's having celiac and just, a cause for fatigue.
Yep.
Vitamin D, making sure you're not having any absorption issues, which we often see with the gut. Just these are all like
Mhm.
little tools to trying to give us clues. Now, in terms of the autoimmune testing, this can go both ways. And I think and I, as a rheumatologist, often have to repeat testing a lot of times when done for autoimmune disease, just because a lot of the generic LabCorp Quest testing facilities, especially for some of our more general testing for autoimmune, like ANA,
Mhm.
are just not really good quality testing. Although the big box LabCorps and Quests have gotten better and are now using better quality laboratory testing for these tests, but it depends on which panel you order, and there's like 6 different kinds. So I mean, if you order it as the primary care, it's fine, but I guess I would help your patients understand though that if an ANA does come back positive, that they not start to panic, that this means that something is actually wrong. And that's the tricky slippery slope with the
Yeah.
ordering the autoimmune tests. They have to be done with the caveat that and I know our listeners may not know what an ANA is, but it's basically a screening test. It's a screening
Mhm.
blood test, but we know that up to 5 to 8% of people like who have no autoimmune disease may have that test be positive. And so it just has to be interpreted.
Yeah.
Unfortunately, there are many primary care doctors who might tell or may imply to the patient that like, oh, this might be lupus in that way that can sometimes be a little unnerving. And maybe the primary care really does think that the patient has lupus, which then in that case, that's great. But I think, because then they're sending them to the specialist to get actually evaluated. But I would say that patients should reserve interpreting those results until they get to the specialist, because that is our bread and butter day in, day out. And the interpretation of the blood test is not done with a reference range, meaning
Yes.
because the ANA is red in the labs and abnormal, that result means it's actually clinically significant. So you
Correct.
can have an abnormal result, but when we put it in the context of your entire clinical picture, that's how we determine whether it's significant or not.
Yeah,
So,
this is the core of all of that is as it turns out, we have to talk to our patients, evaluate them, see what their symptoms are, and
right,
put them in context. The tests are not perfect, just like we as humans are not perfect, but it's all of this data combined to figure out. And as I don't have to tell you, it often takes people, up to a decade to get a diagnosis because maybe the symptoms are evolving with time.
right.
Maybe it's just not clear. So understanding that there's not a perfect test for any of this stuff. But you
But
need, yeah.
I think the reason seeing a rheumatologist is important because there are certain clues, though, that help us kind of put you in certain categories. So, for example, the rash, a rash, for example, there could be very clear evidence that this rash is urticarial related to like an urticarial vasculitis that would be more autoimmune mediated versus just a pure allergic urticarial rash. And there's a lot of the mast cell disorders can cause a lot of flushing. I've seen patients with mast cell disorders who have malar appearing rashes. So malar is the rash that comes across your nose and cheeks that's classically associated with lupus. And the patient, you test them up and down and they really don't have lupus, but they're having this like perfect looking malar rash and they, think that they have lupus. And so again, you just need a trained eye. You need to put it in the context and definitely seeing the rheumatologist to help you with that. But I would say like the basic autoimmune panel, thyroid, vitamin D, iron levels are all, important in terms of blood tests, and then just history in terms of the joint pain. Is it an ache, or are we actually seeing swelling in the joints?
Mhm.
Is it coming in flare-ups that are identifiable with certain triggers like a smell of something or a exposure to something, which really sounds more allergic,
Mhm.
versus there was no rhyme or reason why this rash came on and I have no identifiable reason, which could be a little more of a clue that this is your immune system just dysregulating on its own rather than being triggered by an allergic pathway.
Right.
Again, there can be overlap though.
Yep.
And I've had several patients that can have both at the same time,
Yep.
which is where you need a good team member to work on it together.
That's right. So for folks who are entering this world and saying, "Hey, I just thought it was normal to be hurting all the time and having these rashes and whatever, and finally I've gotten into a Facebook group or, you know, TikTok is telling me that I have MCAS, which is what I hear from a lot of people. And TikTok's not always wrong, you know.
Yeah,
So they're entering this world, obviously a great primary care doc is a good place to start because we could start looking at the big picture. The caveat,
absolutely.
like you said at the beginning, is that a lot of primary care docs don't know about MCAS, EDS, and POTS. So, but they can at least say, hey, I want an autoimmune panel. And even if it's a basic screening panel that's not coming from a specialty lab, then it's a place to start.
Yes.
And then the questions for the rheumatologist would be then, do you think I have this autoimmune connective tissue disorder? EDS is a very tricky part of things because again, it's a disease that not a lot of people own, and getting tested for EDS is a challenge. But I think you're particularly gifted at saying like, this looks like a hypermobility spectrum disorder that gets managed in a different way. Good news, you don't have an autoimmune disease. So helping differentiate
Correct.
between those.
To be honest, I would say that for a rheumatologist, identifying hypermobility syndromes are really, it's not a hard thing for us to do. That's pretty, I mean, I can walk in the room and sometimes just tell the way this
Yeah,
patient is sitting and the
yeah,
way they cross their legs that whether they're hypermobile or not. So that part's not hard. But what I will say is that what can be a little challenging is that we shouldn't have any sort of biases. So just because somebody's hypermobile, it doesn't mean you can't have an autoimmune
that's
disease.
exactly right. Yeah.
And but there are really distinct patterns for inflammatory arthritis, and it's not always the physical exam in that moment, just because a lot of the times these inflammatory symptoms are coming and going. So at that moment, all I see is hypermobility because that's present at all time. But the way that the patient is describing their symptoms oftentimes helps us. So things that help me determine if something is inflammatory, for example, is how long are they stiff in the morning? I mean, you can have some stiffness when you have hypermobility as well, just because you can also develop earlier loss of cartilage and osteoarthritis because your joints are hyperextending. But other things would be, like so the length of your morning stiffness, and then the pattern of the joints that are involved.
Mhm.
Oftentimes, like some of the smaller joints, symmetric, very bilateral. I'm not saying that can't happen in somebody who's hypermobile, but there's just ways of the description of it that really push us more like, oh, we need to dig a little deeper here because maybe this
Right,
patient also has some RA going on or,
right.
another autoimmune. But it's just you just have to hear it like lots of times to be able to identify it. And I don't expect a patient or Google or Chat GPT of entering those symptoms to be able to spit out the with accuracy, mainly because it's sometimes not, it doesn't take one visit. Sometimes
Yes.
I see a patient in evaluation and I'm honestly, after doing a whole evaluation, I'm just not sure. And I
Yeah.
say to them, I don't, I can't rule out though that there may not, like, yeah, I think you're hypermobile. Yes, I think you have clear signs of dysautonomia and POTS. But that autoimmune component, I just can't totally put my finger on it because you do have these positive markers. And so I want to watch. So the other
Mhm.
thing, when we do identify the autoimmune disease, unlike the EDS and the POTS, where, at least at this stage, the majority of what the treatment management is around is either antihistamines and biologics in that category of medication, or a lot of symptomatic management. When you're going in the autoimmune realm, we're talking immunosuppressants. We're talking
Yeah.
things that are going to have all these other side effects. And so for the patient, it's more like, yeah, you may have something autoimmune, but I'm going to monitor you because I still don't think you meet the threshold for me to start giving you immunosuppressant medication. So
Yeah.
it's for the patient to also understand that the label of autoimmune doesn't automatically mean you're getting some magic bullet. And the
Mhm.
lack of that label also doesn't mean that people are like withholding something from you that could have made, you know what I mean? It's like,
Right. Right.
it really, that diagnosis comes with its own set of, issues. And so I know, I mean, I have had many patients who say, well, I just wish I knew, like, if I could just have an answer,
Yeah, of course. Of course.
and of course I understand that, but, it is the nature of the immune system to want to wax and wane and sort of, like you said, take time to reveal itself. But having a good partner, like a good primary care, a good rheumatologist who's along the ride for the
Mhm.
journey to watch what happens as it's longitudinally unfolding. And for some patients, that might even be a once a year check-in if you're not really meeting that threshold, but there's something brewing. It's
Mhm.
very reasonable.
Yeah. All right. So take home is that particularly for folks who are struggling with chronic pain, and we're trying to tease out, is this hypermobility? Is this autoimmune? Is there something else? So to get some basic labs, basic
Yes.
workup, see a trained person who has experience, whether it's a primary care doc or a rheumatologist, someone who understands how to distinguish these things through pattern recognition, test interpretation. And then in the end, getting a diagnosis is lovely, but for the folks who still continue to fall into that gray area, having a threshold of risk benefits of like, when is it enough symptoms to warrant putting you on the risk of medications? And so having a care partner team, especially people who understand this kind of niche of medicine, is super helpful. Thank you so much for being with us today. I really appreciate your insight. Thank you. And can you
Fun.
tell us where people can find you if they are looking for someone to take care of their autoimmune disease?
Sure. So I'm my Instagram handle is Integra Health MD. If people want to find me there, or in Integra Health on Facebook. And I'm here in Atlanta like you, and excited about a new practice I'm launching in a couple of weeks actually. So I've been practicing rheumatology for 20 years, but doing it a little different, and looking forward to this next stage. So I'll be happy
Awesome.
to
Thank, thank you
see.
for being here. All right.
Thanks. Bye.